Hi, my name is Clinical Clinus and you're watching the video on the characteristics of intermittent exotropias. An intermittent exotropia is, as the word suggests, where we have a patient who has a tendency for one eye to deviate outwards some of the time. So these patients will be intermittently controlled, whereby you'll usually find an exophoria, and intermittently manifest where you'll find an exotropia. Now, during the manifest phase, usually these patients with intermittent exotropia have suppression. Some may complain of diplopia, but that's actually quite rare. More often, the patient will suppress during the XT phase. And of course, during the controlled phase, you should be able to demonstrate BSV. So that might be using a stereo acuity test or doing a test such as Baglini striatal glasses. Those tests should indicate to you that the patient is aligned during that time. Okay, before we proceed to discussing intermittent exotropias, I want to address again the question of how do we distinguish between a patient who has an intermittent exotropia versus a patient who has a decompensating exophoria. Now, you'll be well aware by now that a decompensating exophoria means that the patient may be intermittently manifest, which is very similar to the intermittent XT patient where they're intermittently manifest at times. Here is a table from Ansons and Davis which highlights various diagnostic features that assist you in distinguishing between whether the patient has a decompensating exophoria or an intermittent exotropia. I'm not going to go through the entire table, but what I want to come back to is what I've mentioned previously, which is that one of the key findings that distinguishes the two is the presentation of the patient and their symptoms. Generally, a patient with an intermittent exotropia is not aware of the deviation or when the eye deviates, and they're not symptomatic in the way that a decompensating exophoric patient is. So they don't experience those asthenopic symptoms of eye strain. On the other hand, the decompensating exophoria patient will present more often than not with those asthenopic symptoms that are directing you to the possibility that the patient is a decompensating exophoria rather than an intermittent XT. Okay, moving on to classification, I have here again the part of the table that relates to patients with a primary exotropia, where we have an intermittent deviation, and we can classify the patient as either having a divergence excess, convergence weakness, or basic intermittent exotropia. Again, the terms relate to the deviation and the comparison between the deviation near and far. For divergence excess, the deviation is greatest at far and the patient is aligned at near. For convergence weakness, the patient's deviation is greatest at near and the patient is aligned in the distance. And for basic, the angle of deviation is relatively equal between near and far. And so the intermittent deviation occurs, or the manifest phase of the deviation can occur either at near or distance. So generally speaking, for divergence excess, the XT occurs in the distance. For convergence, the XT occurs at near. And for basic, it occurs at both distances. Now, we'll talk about constant deviations a little bit later, but it's worth noting at this point that the intermittent XT is the most common primary exotropia, and that the divergence excess exotropia is the most common intermittent exodeviation. Now, here I've provided you a summary table of some of the expectations we have of patients with the various types of intermittent XT. So let's start off with that cover test result. When we have a basic deviation, we expect that there will be an intermittent deviation at near and far, and that the deviation size won't exceed 10 diopter difference between near and far. For the convergence weakness, what we see is that the patient is manifest at near, controlled at far, and the difference between near and far will exceed 10 diopters. And for divergence excess, what we see is usually control at near and manifest deviations in the distance. And we'll talk about this in a moment, but we usually also perform the test at greater than 6 centimetres when we notice that there is a divergence excess pattern. And so here we see that as the patient looks further and further into the distance, the deviation size increases. Now, in terms of what causes the various types of intermittent XT, this is relatively difficult at times to determine, but it could be anatomic or kinetic factors such as refractive errors and IPD. In relation to basic types of deviation, these can actually be patients who were once divergence excess exotropes but have slowly become basic or non-specific. What this means is that over time, this patient here, for instance, where we've got 10, 20 and 35, over time, these distances here increase to about 35. So what you see is that it collapses into being a basic deviation. So here is an example of where patients can actually change in relation to their classification of the exotropia over time. In relation to divergence excess, you'll see here I've also listed a few other potential reasons for the development of divergence excess, but overall it's relatively unclear why these patients develop the condition. Now, moving on to what do we expect of these patients on other investigations, what I've included here are the tests again that we're more likely to see an issue with or where we may see an anomaly. So with the basic deviation, in some instances the convergence near point will be reduced, and with regards to visual acuity or binocular functions, these are at risk depending on how frequently the deviation is manifest and then the onset. So as an example, if the patient is very young and the deviation is manifest most of the time, so let's say 80% of the time, that patient is at risk of amblyopia and a reduction in binocular functions. With convergence weakness, this is often associated with a reduction in convergence near point, and these patients are often also diagnosed with convergence insufficiency. Now, in relation to visual acuity and binocular functions, because these patients are aligned at one distance, generally that is sufficient to allow visual acuity to develop normally and equally, and for binocular functions to develop. And finally, with relation to divergence excess, I'll come to that in subsequent slides because divergence excess is a relatively complex condition as compared to basic and convergence weakness. Okay, so let's focus now on divergence excess intermittent exotropia or distance exotropia. This is, as I've mentioned before, the most common type of intermittent deviation that we see and is the most common primary exotropia that we see. So in relation to the history, when you're taking the history, ask about the onset of the deviation, and generally it occurred, or the exotropia will have been noticed during infancy or early childhood. The other question you want to ask is how frequently does the parent notice the exotropia? Now, generally I'll ask the patient what percentage of the day do they notice the deviation being manifest. So is it 50% of the day, 20% of the day, 80% of the day? And the reason this is important is because if the deviation is very frequent, then the patient is at risk of losing their binocular functions, and that may trigger us to treat the patient earlier than we may otherwise do so. Now, patients with divergence excess intermittent exotropia may present with symptoms. However, more often than not, they don't complain of symptoms. They usually present because the parent has noticed that the eye is deviating outwards occasionally. But some of the things that can be noted, and the most common thing that's noted, is that the patient may close one eye during sunlight or when they're in bright sunlight. Now, we don't understand really why patients with specifically divergence excess exotropia close one eye in bright sunlight. However, it is a classic sign of this condition. So, if a patient comes into my room and if the parent says that they've noticed that their child closes one eye in bright sunlight or when they're playing outside, I am looking for a divergence excess exotrope. It is the symptom that is associated with this condition. Now, other symptoms that you might elicit from the patient, or you can ask questions with regards to, is that intermittent XT patients can experience panoramic vision. So when the eye is exotropic, there's an increase in their visual field. Sometimes the patients may complain of blurred vision, and this is usually because they're trying to take control of the exodeviation through the use of accommodation, which then blurs their visual acuity. And some patients, not always, may complain of diplopia. As I indicated earlier, many of these intermittent XT patients usually experience or have suppression during the XT phase. Okay, one other thing I'd like to point out is the natural history of this condition. Now, what I mean by natural history is what do we expect will happen to this condition over time if we never intervened? Does it become worse? Does it become better? Does the patient learn how to control it? They're the sorts of questions we're asking around natural history. And it's important to understand the natural history of divergence excess intermittent XT, because it's something that needs to factor into whether you're going to manage the patient or not. And the issue with this condition is that the natural history is variable between patients. So some patients will improve over time, where you'll see the frequency of the manifest phase will become less and less, and the patient will learn to control the deviation more and more. You may even be able to introduce orthoptic exercise a little bit down the track when the patient is older and assist that control even further. For other patients, it can get worse. The deviation becomes more frequently manifest, in which case you have an issue around the potential loss of binocular functions and the development of amblyopia. Okay, now we saw earlier on the flow chart that we have two types of intermittent divergence excess exotropias, the true and the simulated. The difference is that essentially for a simulated divergence excess, which is the majority of your patients, you can actually find a reason for why the deviation is smaller at near and controlled at near. Whereas for true divergence excess, you cannot find a reason why that deviation is smaller and controlled at near. Now, for the simulated patient, there's one of two reasons why the patient will have a smaller exodeviation at near. That is, either they have a high ACA ratio or the patient is utilising slow fusional divergences to control the deviation at near. Now, depending on what textbooks you read or what papers you read, the term for this can vary. Kushner introduced the term tenacious proximal fusion, which is exactly the same as the convergence after effect, or what we're talking here is about these slow fusional divergences that are dampening the size of the deviation and allowing the patient to be controlled at near. Now, how do we work out whether the patient has a high ACR ratio or has TPF, which is the cause of the divergence excess pattern? Well, firstly, we occlude the patient for 45 minutes. If you go back to your notes about slow fusional divergences, one of the ways to decay the slow fusional divergences is by occluding the patient. So what we need to do is occlude the patient at minimum 30 minutes, but generally for at least 45 minutes. And this will vary depending on, again, textbooks or papers that you read. But if you occlude for 45 minutes, you should be safe in terms of decaying TPF or those slow fusion divergences. Now, if the patient is actually controlling the deviation using TPF, you'll see an increase in the deviation at near. So as an example, let's say it was 10 diopters at near and 30 diopters at far. After 45 minutes of occlusion, what you will see is that the near deviation will go from 10 to 30. So we see this increase in the deviation. And that says that it was TPF that was resulting in the divergence excess pattern. In order to find out whether the patient has a high ACA, well, obviously what we do now is we measure the ACA. But it's important that you measure the ACA, particularly if you measure them at near with +3 lenses, after occlusion of Marlowe, so after the 45 minutes of occlusion. And the reason we do this is because it's important that you elicit the true size of the deviation at near. The only way to do that is through occlusion of Marlowe. Okay, let's discuss this using a patient example. So here we have Craig, who has an exophoria at near and an exotropia at far, and the measurements are 10 diopters at near and 40 diopters at far. And so here we see the same example, 10 diopters and 40 diopters at far. Now, let's measure the ACA ratio before occlusion of Marlowe. So in this instance, what we've done is we put up +250s at near, and the patient has a 35 diopter base in exo deviation with these plus lenses. And so we will compare the near 10 to the 35 with the lenses on, as we see here, and divide by the lens provided, which is 2.50, and we end up with a 10:1 ratio. And we would conclude on the basis of this that the patient has a high ACA ratio and that they have a simulated divergence excess XT based on having a high ACA. Let's have a look at what might happen differently if we occlude the patient. So here we will measure the ACA ratio after occlusion of Marlowe. So after occlusion, the PCT is performed again, and what we find is now that at near we have a 35 diopter exo deviation, far of 45, and then we put up 250s at near, and we find that the patient has a 45 diopter base in. Now what we see is that post-occlusion, what's happened is that the near deviation has significantly increased as compared to what it was pre-occlusion. So it's gone from 10 to 35, and what we see is that it's increased to almost the size of what the far was previously, and we see that far has also increased slightly. Now, the reason why the deviation has increased post-occlusion is because of the decay of slow fusional divergences, or the convergence after effect, which means that this patient, or the reason why this patient has a divergence excess pattern, is due to the presence of TPF, which is why the deviation is smaller and controlled at near. And then if we proceeded to measure the ACA ratio, what we'd see is that we'd have 35 minus 45, so the near deviation with no lenses versus the near deviation with lenses, and we'd have a 10 over 2.5, which gives us a 4:1 and a normal ACA ratio. So in this instance, Craig would be diagnosed as having a simulated divergence excess exotropia, but for a different reason, because of TPF. And what we can see here is that our determination of whether a patient has a high ACA ratio or not in these patients can be contaminated by TPF, and so we must decay that first before we measure the ACA ratio. Now, the effect on the ACA ratio isn't as great if you assess the patient in the distance, because in the distance, obviously TPF isn't playing as much of a role because it's being utilised at near, not at far. So if you don't have time in clinic to occlude your patient for 45 minutes and you want to measure the ACA ratio, you must do it in the distance so that TPF won't contaminate your ACA ratio. Okay, here is a flowchart from Ansons and Davis which summarises this discussion around the occlusion of Marlowe and what to expect. So what we see here is that if the cover test is suggesting a divergence excess intermittent exotropia, we perform the occlusion of Marlowe, and one of two things is going to happen. Either there's going to be no change in the angle at near, or there's going to be an increase of the deviation at near. And usually what we'll see is if there's an increase in the deviation, the near deviation will be almost exactly the same as the distance deviation, in which case you have a simulated divergence excess XT, and this patient has TPF, which is causing the deviation to be larger at near, and will generally have a normal ACA ratio. On the other hand, we have no change in the angle of deviation at near with occlusion of Marlowe, in which case what we now want to see is what happens to the deviation with 3 diopter lenses. And let's assume we've put +3 diopters at near. Now, if the deviation increases at near, generally we're going to find a high ACA ratio. So without the lenses it'll be smaller, then we'll see a significant increase with the lenses, in which case the patient will ultimately be diagnosed with a simulated divergence excess XT with high ACA ratio. The alternative is that you put up the +3 lenses and there's very little change in the deviation at near with and without the lenses, in which case your patient ends up being diagnosed as having a true divergence excess exotropia. So ultimately, the true divergence excess exotropia, you find that the patient has a normal ACA ratio and the patient isn't utilising TPF to control the deviation. In other words, there is no increase or significant increase in the size of the deviation at near with occlusion of Marlowe. Okay, before we conclude, what do we expect on some other investigations that we may perform in a divergence excess patient? In relation to visual acuity, these patients tend not to be amblyopic because they're controlled at near and only manifest at one distance. In relation to the cover test, we've already discussed this, but I want to highlight here that where you see a divergence excess pattern emerging between near and far, you should always perform a greater than 6 metre measurement. And to do this, usually you'll need to ask your patient to look outside a window or down a corridor or somewhere where the patient can relax their accommodation. The reason that you should do greater than 6 metres is that some surgeons prefer to operate on the deviation at that distance, at the greater than 6 metre distance. In terms of ocular movements, these patients at times do show ocular movement anomalies. So always assess ocular movements, but you would do so in any patient with an ocular motility disorder. Convergence near point, generally this is normal, but you should monitor it, and any reduction in the CNP is often an indicator that things are worsening or progressing. Now, finally, when we're investigating these patients, we want to determine how well controlled the intermittent divergence excess exotropia is. Now, one of the things that we'll have done during the history taking is I've asked the parents, how frequently do you notice the eye turning? And so again, if the patient is saying it's 80% of the time, or the parents are indicating it's 80% of the time, we've got poor control, as compared to 20% of the time, which indicates good control. But in clinic, we can do a couple of other investigations. One is we can assess binocular visual acuity. By assessing binocular visual acuity, we have an indication of control. Now, because divergence excess intermittent exotropia is such a common condition and can be a dilemma in terms of when do you manage this patient or surgically intervene, various tests or tools have been developed to assist us in measuring the control of the deviation. Most prominent is the Newcastle Control Score, and we see it over here to the right. Now, the score takes into consideration the frequency that the parents notice the eye turn, and then what you observe in clinic in terms of how quickly the patient regains control at near and at far, and then the patient receives a certain score, which is an indication of how well they control the divergence excess exotropia. Now, this really isn't utilised very frequently in clinic. However, many research papers have begun utilising or discussing these types of tools in the assessment of patients with divergence excess exotropia. So they're worthwhile knowing about, and you may be interested in utilising these in your clinic. And finally, I've made a note there about binocular functions, which ties into control of the deviation, in that when that deviation is controlled, you should be able to assess or demonstrate that the patient has BSV. And of course, when they become manifest, more often than not, they will suppress, in which case you'll get a suppression response during that time. And it's the frequency of that suppression that is what puts that patient at risk of amblyopia and losing binocular functions over time. Okay, that brings us to the conclusion of this video. Thank you for watching.